Good afternoon. This is Marie-Josée Brouillette. It's a pleasure for me to welcome you on behalf of the group to this virtual session on brain health and HIV. Our group has been studying cognition in HIV for almost 10 years now, and our goal was always to develop a coherent approach that could be used in the clinic setting. I'm very pleased to report that we can now propose new views and practical tools to assess and manage brain health in HIV in the Canadian context. We have no conflicts of interest to disclose. The interest in including assessment of cognition in the routine care of persons living with HIV was prompted by several studies that documented that with the introduction of HART, the prevalence of HIV-associated dementia, here in green bars, decreased markedly, but the prevalence of the mild cognitive impairment increased, and even with good viral control, and that this mild cognitive impairment is associated with functional impairment. So we're no longer dealing with the dementia that was associated with a very poor prognosis in the context of multiple other complications of AIDS, but now are dealing with a condition that is present in those who are go on living and is associated with functional impairment. So to reflect this emerging reality, in 2007, the research nosology for HIV-associated cognitive disorders, or HAND, was updated in 2007. That's a full 13 years ago. That classification is based on neuropsychological testing, which is not available in the clinic setting. So even though the updated nosology was published 13 years ago, the evaluation and the treatment of cognitive difficulties is not yet integrated in the routine follow-up of persons living with HIV. Why is that? One reason I think is that most of the literature aiming to make this possible in the clinic setting has focused on this question. Does the patient have HAND? Finding a screening tool for HAND. Multiple studies have reported on the psychometric properties of various tools that can be used to screen for the presence of HAND. While it's relatively easy to screen for the presence of dementia, it's much more difficult to screen for the presence of mild cognitive disorder, so that the performance of these screening tools is generally poor. But the other reason for ignoring cognition is, so if the patient does have HAND, what do you do? While the attention is on the search for the screening tool for HAND, clinicians are left with very little guidance on what to do. The point I want to make in the presentation is the following. Clinically, we have to move away from that question, does the patient have HAND? I realize that I'm suggesting to deviate from the prevailing approach, so today we will present some of the evidence that supports this recommendation. After today's session, hopefully, you will be both convinced that we can move away from that question, but also excited by the fact that the approach that we are advocating is not only feasible clinically, but also supports therapeutic interventions. So the learning objectives are, at the end of this session, you will be able to identify the strengths and limitations of different methods of assessing cognition in HIV, list the major contributors to successful aging, describe the neuroimaging findings and their relationship to cognition and clinical factors, and recognize points of intervention to improve brain health. I want to mention that we will be focusing on mild cognitive impairment, not on dementia. And this is an important point because in dementia, you could find severe impairment on neurocognitive testing in someone who doesn't have any subjective complaints. So this is not what we're going to be focusing on. We're going to be focusing on mild cognitive impairment because that's the form that it predominates in the setting. So if we move away from the question, does the patient have hand? How do we integrate the fact that people with HIV may experience cognitive difficulties in the clinic setting? Let's go back to the drawing board. We care about cognition, and patients care about cognition because it has impact on function and on quality of life. Whereas cognition is typically assessed for several cognitive domains, such as memory, executive function, and so on. For the clinician, it would be much more convenient if cognition was represented by a single value of severity, a little bit like a viral load, a value that would be easy to interpret and that would make it possible to monitor change over time in a specific patient. But can cognition be represented by a single value that is both valid and meaningful? The answer is yes. We have shown that performance on multiple cognitive tasks can be combined to create a single valid score of cognitive ability. You can look at cognitive tasks as representing function in a certain domain, such as memory, for example, but you can also look at the same task in terms of how difficult they are, irrespective of the cognitive domain that they tap into. Whether this is a test of memory or a test of executive function, how difficult is this task compared to other tasks that either tap into the same cognitive domain or even other domains? We have tested this approach extensively using data from our study as well as data from other cohorts. So once we have established that using modern statistical method, we can combine tests from different cognitive domains, we have developed a brief computer-administered measure of cognition that we named the BCAM, and that is used in our Brain Health Now study. We are continuing to optimize the BCAM, and our goal is to make it available to clinicians and researchers as a measure of cognition that is brief, that can be administered with minimal training, and that produces a valid score. Now, when assessing the impact of cognition in real life, we have to keep in mind that cognitive difficulties are often accompanied by other symptoms that can also have an impact on function, such as anxiety, depression, fatigue, and pain. It may be difficult to disentangle the respective contribution of each factor. We have to acknowledge that this is a complex problem that may be best addressed by interventions that consider this complexity. Now, in terms of understanding what it is about HIV that could lead to the development of cognitive difficulties, again, there is not a single answer. Dr. Fellows will be talking about the role of nadir CD4 cell count and cardiovascular risk factor. The potential toxicity of HIV meds has also drawn attention. But finally, to best understand how the body and the brain function in real life, we need to consider other factors related to both the individual and their. If we combine performance on all these cognitive tests, we cannot make a diagnosis of hand. How big a loss is that for the clinician? Do we need a hand diagnosis? It's not because we develop a measure that is valid that it necessarily means that it's useful. So we address this question by asking what is associated with function and quality of life, a diagnosis of hand or a quantity such as the BCAM. We decided to look at two aspects of function, because we're looking at higher levels of functioning. So we looked both at work status, is the person working or not, but also productivity at work. This was represented in our study by presenteeism, which is the practice of going to work in spite of illness that often results in reduced productivity. So if we look at work status, both a diagnosis of hand and the BCAM, the brief computerized test, predict status. Now we also wanted to look at productivity because when people are diagnosed and treated early, we expect that they're going to continue working for longer. Unfortunately, neither a hand classification nor a score on the BCAM are associated with productivity. Does that mean that cognition does not play a role in decreased productivity? Well, not exactly. What is associated with presenteeism is cognition as assessed by asking people about their symptoms, not by performance-based cognition. Now, cognitive symptoms have a bad name. They're often seen as unreliable as opposed to measured cognition. There is a correlation between symptoms and performance, but the correlation is not perfect. We've known for a long time, for example, that a depression is also associated with increased reports of cognitive difficulty. And this is not only in HIV. When you think about it, this is not so surprising. For memory, for example, if you test memory as part of neuropsychological testing, this is done in a controlled environment, the room is silent, you have nothing to do but to pay attention to what the examiner is saying. But in real life, this is not how it works. You're bombarded with all kinds of information, you're trying to multitask, so you may not perform as well as you did in the setting of neuropsychological testing. Symptoms are about your perception of your cognition in real life, so it's not surprising that it correlates better with real-life performance than neuropsychological testing does. So cognitive symptoms are a very important source of information about cognition. Measured cognition is one of the determinants of cognitive symptoms, but not the only one. So in summary, cognition can be approached by level of difficulty rather than by cognitive domain, and this will give you one number to reflect cognitive ability. Neuropsychological testing should be reserved for situations in which you require an expert interpretation of the result, not for diagnosis. So I am not against neuropsychological testing, and I do refer on a frequent basis to our neuropsychologists for very important questions. For example, we have refugees who appear in front of the board and appear to be lying, and this could put them at risk, in fact, of being deported. So we need to carefully document what's happening with their cognition, and if it's shown that for emotional reason or as a result of traumatic brain injury following severe beating, they are impaired cognitively. This is really a life and death issue, but I would certainly not ask our psychologist to apply strict criteria to know if the patient has hand. Cognitive symptoms are very useful in providing information about function and quality of life, and here we have something for you, and Dr. Mayo is going to be presenting that in a few minutes. For the researchers, I would invite you to think twice about the question. If you're doing a study, to improve cognition, does the patient have hand? Does the patient not have hand? Is cognition improved? You should be thinking twice about what your question is, because if you want to focus on the patient's function, you certainly would want to document symptoms. And then if you find cognitive difficulties, what do? Stay tuned. I'll come back in a few minutes with an answer to that.
Thank you, Mary Jose, for that introduction, and the information presented pointed out the importance of cognition, whether measured or self-reported, for constructs related to everyday living. This talk is going to link cognition to successful aging. I'm new to the area of HIV, and I come from the world of rehabilitation. And one of the aspects of rehabilitation we find important is considering what the person can do rather what they can't do, and consider that the glass is half full rather than half empty. I was struck when I started working in HIV how much attention is paid to the negative aspects of aging with HIV. For example, frailty. I found less attention was paid to those doing well, thank you, yet much could potentially be learned from aging successfully. What is successful aging? In fact, there are over 25 definitions of successful aging, leading to prevalence rates of 1 to 94%, which of course raise more questions than answers. The most common definition of successful aging is the avoidance of disease and disability, maintenance of high physical and cognitive function, and sustained engagement in social and productive activities. Other suggestions are to use values on physiological parameters, tests of physical capacity, and there's been a suggestion of using self-reports of health and well-being. What hasn't been resolved is which tests, which values would we use, which self-reports. How is this data made available? How do you interpret results from multiple tests and multiple parameters? What is the clinical relevance of this information, and what is actionable? We look to the literature for knowledge about what factors people have considered that relate to successful aging. In fact, it seemed that physical and functional disability was common to all definitions and theoretical models for successful aging. Based on the literature, we were able to develop a theoretical model for successful aging based on personal and environmental factors, and also biological, lifestyle, cognitive, and resilience factors. For healthy aging, self-reports are a practical solution. There are many well-known and widely used generic measures of health status and health-related quality of life, and there are population norms in many countries to aid in the interpretation. In Canada, we have norms for the SF36 and the EQ5D. We chose in our study to use the SF36, and the RAND version is the open source version. The outcome of the SF36 are 8 subscales related to practical and necessary aspects of healthy living and health status. These include physical function, pain, vitality, social function, achievement of important roles, mental health, and self-reported health. We chose 7 or 8 of the subscales at norm to be the criterion measure for successful aging. As successful aging is a positive outcome, the factors that we have identified from the literature are considered promise factors. We tested this model in our brain health cohort on the sample over age 50, some 458 people. We had information on biological factors and all of the other factors listed in the theoretical model. To note, over 50% had age-defining illness in this cohort. Who is not in the cohort will become an important factor when we start looking at the prevalence of successful aging. By design, we did not include people with dementia or other neurological conditions or younger people. By choice, people did not enter our study who were working. They were too busy to meet the demands of the study, and they reported better self-reported cognition. The proportion of people meeting age and sex-specific norms on these 8 important life areas are shown in this figure, with red for women and blue for men. As can be seen, that the highest proportion meeting norms was for physical function and role interference, but these remained less than 60% of people met even these areas. We also show the number of subscales that were at norms. For example, 20% met none of the 8. And our criteria, 7 or 8, was met by 14.2% of the sample. This likely actually represents a small proportion of those who meet norms, because if you remember, we did exclude people excluded themselves from the study who were actually doing well, and so 14% is probably an underestimate of the number of people doing well. The proportion of people doing well on these subscales was actually stable over time, and this allowed us to look at baseline factors related to successful aging. In fact, this graph shows that the vast majority of people were stable in their trajectory of meeting these subscales over time. Having arrived at a definition of successful aging, meeting 7 or 8 of the subscales, we now turn to looking at the factors associated with it, and particularly cognitive factors. Where do we get information about cognitive ability? Well, as with successful aging, self-reports are practical. They're very easy to do longitudinally. They're relevant to the person, and when asked in a standardized way, they're good for clinical assessment and for research. But you have to ask the right questions, and we had almost 2,000 people helped us ask these good questions. We developed content from 292 people with HIV in Canada and from other countries. We asked people to look very carefully at the importance and clarity of the items we were suggesting. The item hierarchy was tested in some 204 people, and we were able to reduce 48 items to 18 non-redundant items. We tested whether this hierarchy was the same for community controls. We confirmed the item hierarchy in a larger sample and identified that 10 of the items could be used to classify people according to different values on the C3Q, and we are re-administered also to age-matched controls. Based on this information, we created a measure of self-reported cognitive ability called Communicating Cognitive Concerns. A feature of this measure is it has ruler-like properties in that the values along the scale, like a ruler, have interval-like properties and can be interpreted actually as values. Our HIV cohort scored 70 out of 100, and our HIV negative group scored 80 out of 100. We put the scale from 0 to 100 to aid in interpretation because we're all used to grades, and the HIV negative would have scored an A- on cognitive ability, and the HIV positive would have scored a B. When we designed the measure, we wanted to keep it as structurally simple as possible with as few words to read as possible. Therefore, we created a root, like I forgot or can't remember, and a list of areas that the people with HIV identified as important. We have 3 groupings of areas: memory, concentration, and other concerns. What is in gray are the 10 items that are crucial for deriving scores. Activities I need to do, what I was about to do, losing focus on a conversation or doing complex tasks, and being organized as examples. People with HIV reported experiencing more cognitive concerns than HIV negative. The ordering of this item is from the easiest item, where few people have cognitive concerns. I forget I have food cooking, that's thankfully. To a harder item where more people had cognitive concerns. Forget what I was about to do. This is one of the features of using rash analysis to order the items. This slide shows the relationship between the C3Q, our measure of cognitive concerns, and healthy aging. Along the x-axis are the numbers of subscales that were met at norm or above, and on the y-axis is the score on the C3Q. The red line shows that there was higher scores on the C3Q with more subscales met. In the red box is our criterion for successful aging. At the green line at the top is the maximum value, and the blue line is the minimum value. What can be seen also from this slide is that success, having a high score on the C3Q is not a sufficient condition for successful aging, because a proportion of people with meeting very few SF36 subscales also had a high score on the C3Q. We also learned that cognition is not a necessary condition, as there are people who scored only 50 out of 100 on the C3Q also met our criteria for successful aging. However, there was no relationship between measured cognition and successful aging, underscoring the importance of asking people how they are doing when considering other important health outcomes. People with HIV who were classified as successful agers were also classified by the following factors. They felt safe in daily life, they had meaning in life, they had opportunities for leisure, they had a good social network, they were not lonely, they had sufficient money, they were optimistic about the future and had plans and goals for the future. In conclusion, the probability of successful aging was determined by these three areas: cognitive concerns, resilience factors, and environmental factors. Are these areas actionable? The resilience factors and the environmental factors fall under social determinants of health and are actionable through changes in social policy and also through the HIV community support groups. Cognitive concerns are actionable through self-management areas, and in fact we have developed a poster and a workbook for self-management of cognitive difficulties. I would like to thank the participants in the Brain Health Now cohort, and also the wide range of investigators, research assistants, and community partners that helped put this project together and ensure the access to data. Thank you.
Hi, my name is Leslie Fellows, and I'm a cognitive neurologist and a neuroscientist based at the Montreal Neurological Institute. And I'll be presenting to you on some of our recent work on neuroimaging in HIV. Before I start, I just want to mention the people who actually did this work. Ryan Sanford, in particular, a PhD student in biomedical engineering, who was working with Louis Collins, my colleague at the Montreal Neurological Institute, who's an expert on MRI image analysis. So we were hearing about various ways we might understand how people are doing with respect to their brain health. asking them, testing their cognition. And now I'm going to speak briefly about what we might learn by looking at the brain using neuroimaging. There are a variety of methods to look at the brain. Structural MRI is probably the most widely used. It's used clinically, principally to exclude other diagnoses in people with HIV who present with cognitive or other neurological symptoms. From a research standpoint, structural MRI can give us insights into mechanisms that underlie cognitive impairment. We can also look at brain function directly using a functional MRI, for example, or EEG. And our group has done some work with those methods, but I will not have time to talk about that today. And finally, you can look at brain function with cognitive test performance, such as neuropsychological tests or our BCAM version, for example, or at cognition as it plays out in the wild. That is how people are managing the cognitive demands of their day-to-day function. Neuroimaging has been applied to try to better understand what's going on in people with HIV who have cognitive difficulties or simply in people who have HIV infection. The approaches used, the analysis methods vary quite widely across studies, which may make it difficult to synthesize the results. The designs are often comparing people with HIV with people without HIV, and that leads to challenges to know how those two groups should be matched, what other variables should be matched. Finally, imaging is expensive, and that means samples tend to be small, which can also explain some of the variability in the literature. Perhaps some of the most important insights into the brain mechanisms would come from longitudinal data, but for the moment, these data are relatively scant. I'm going to take you through 3 studies fairly quickly to show you some of the work that we've been doing and to give you a sense of the literature. The first looks at structural MRI in 133 people living with HIV, recruited from the infectious disease clinic of our collaborator, Bo Ansis, a HIV neurologist based at Washington University, St. Louis. The mean age in the sample is 47 years, and 3/4 of the patients had undetectable viral load. There were 66 age-matched community controls with an effort to match on demographic and socioeconomic variables. All underwent 3 Tesla structural MRI, and we used cutting-edge structural imaging analysis approaches to look both at the cortex and the subcortical structures. Here in the first image, I'm showing you the difference between the group with HIV and the group without in terms of their cortical thickness. So the colored areas show you where there were statistically significant differences between the group with HIV and the group without HIV, and numerous regions of the cortex, really all different lobes of the brain, shows thinning of the cortex relative in those with HIV. This cortical thinning was not associated with indicators of HIV severity, such as the nadir CD4 count, but the cortical thinning did relate to cognitive performance on neuropsychological tests, suggesting that it was functionally relevant. In the same sample, we can look with a different method at the subcortical structures in the brain, so basal ganglia, thalamus, and the brainstem. And here we see smaller subcortical volumes shown in the colored areas, numerous subcortical regions in those with HIV compared to those without. This is consistent with the literature. This is one of the more robust findings in the literature. Although the fine details vary, the general finding is that basal ganglia, thalamus, and brainstem may be smaller in patients with HIV. And that volume difference is related in our sample to a nadir CD4 count, suggesting that it has something to do with severity of infection pre-treatment. One possibility is that this is a legacy effect of injury that occurred at the time of initial infection. But the work I'm showing here, and indeed the literature at large, doesn't necessarily address the mechanism, which could be a third variable correlated to severity of infection, for example. An important question in interpreting the structural changes in those with HIV compared to those without is to ask whether or not this is an ongoing change. Is this an ongoing volume loss or ongoing cortical thinning? Or is this a static effect that dates from early in the injury? And this study addressed that question in a sample drawn from the same clinic in Washington University. In this case, we focused on patients who were aviremic. And he also had absence of evidence of cerebrovascular injury that I'll speak about in a moment. On the theory that we already know that people with cognitive impairment in HIV, the first step should be to make sure they have adequate viral control. So focusing on such patients here, we looked at scans on a median of 2 years apart in the same people and a minimum of 1.5 years apart, comparing 48 people with HIV with 31 HIV negative controls and using these advanced imaging analysis methods. And the main result is shown in this figure. On the top, we're looking at cortical thinning, similar to what I showed you earlier, and on the bottom at subcortical volume differences. And the main finding is that the HIV negative group across the board in orange compared to the HIV positive group across the board, as I showed before, the HIV positive group has thinner cortex, numerous regions of the brain, and smaller subcortical volumes than the HIV negative group. However, what's important is comparing baseline to follow-up, and we found no clinically meaningful brain volume loss in this sample over 2 years of follow-up. So although there are differences, these differences are consistent over time. We do not see ongoing shrinkage of the cortex or the subcortical structures over 2 years of follow-up in these aviremic patients. This is good news. This is encouraging that the differences we're seeing are relatively static. A third study looking at a different potential contributor to brain health in HIV focused on microvascular brain ischemia. So this is an idea that's gaining some traction, that at least some of the brain dysfunction that we may be seeing in well-controlled patients is maybe related to cardiovascular factors affecting the brain. And one indicator of that is something called white matter hyperintensity. This is a signal change that's evident in MRI around the ventricles and in the subcortical white matter. This is a frequent finding in older people in general. It's been associated with cardiovascular risk factors in the general population and is also associated with worse cognition in the general population. And here we looked at cerebral small vessel disease in 119 HIV positive individuals, 55 HIV negative, drawn from that same clinic with a mean age of 55. And basically, there's a couple of messages in this main slide. The first is that the white matter hyperintensity lesion load in this sample as a whole was associated with older age and with hypertension and almost with smoking, as consistent with the larger literature and irrespective of the HIV serostatus. The white matter hyperintensity lesion load was not predicted by HIV serostatus. This was a seemingly independent factor contributing to cognitive performance. So in this panel, I'm showing you that the greater the white matter hyperintensity lesion load, the worse the cognitive performance. Those with HIV positive compared to those who were HIV negative also had worse cognitive performance. Age affected cognitive performance, and education protected cognitive performance, well known. So the conclusion we had with this that HIV status and white matter hyperintensity contributors were independent and both contributing to cognition measured with neuropsychological tests in this study. What's important to mention is that the white matter lesion load in this sample predicted subcortical volume loss and cortical thinning that I talked about earlier. So it is one of the factors that may be contributing, at least in some patients, to the brain differences that we observed in earlier cross-sectional data. So I showed you quickly a few different things. Let me summarize here. First, I showed that structural brain differences can be identified at the group level in middle-aged to older HIV-positive groups. The most robust finding probably is these smaller subcortical volumes that are seen in numerous studies at this point, both in the pre-CAHR and the CAHR era. Thinner cortex, the details of which bits of the cortex may be thinner vary across studies, but there are a number of studies that have shown differences in cortical thickness. The mechanisms remain unclear from this work. The mechanisms could include injury at the time of untreated infection. They could include ongoing or past cerebral microvascular ischemic change. And it could include other factors that have not been studied in this work, For example, social isolation and stigmatization that we and others have found relate to cognitive performance may lead to structurally evident changes in the brain. That's something we've seen in older samples, HIV negative samples, and we're currently studying that now. It's possible that drug treatment toxicity from CAHR could be a factor, but we looked for that in the work I showed you here, and there was no evidence. This is, though, hard to study in these observational studies. I want to underline again the fact that those patients who were aviremic on treatment, who did not have white matter hyperintensities, in those patients in the median follow-up of 2 years, brain volumes did not substantially change. This is more in line with a legacy effect than with an ongoing degenerative process. And I think it's very reassuring and also aligns with results we've found in other work looking just at cognition, suggesting that the vast majority of people with HIV on treatment have relatively stable cognitive performance over time, even if they may be performing somewhat worse than otherwise healthy samples at any given point in time. And the practical point, finally, is that in the clinic, for the moment, imaging is still mainly used to rule out other unexpected causes of cognitive symptoms in people with HIV, and that these subtle structural changes that I've showed you cannot be discerned in an individual person, although perhaps these research methods could be applied in the clinic someday. For the moment, they're not. However, white matter hyperintensities are interpretable on an individual basis. And if you see a prominent white matter hyperintensities in a person with cognitive difficulties, you may, that may be yet another reason to more aggressively treat any cardiovascular risk factors they may have in an attempt to stabilize or slow ongoing brain injury due to ischemia. So with that, I'm going to turn the podium back over to my colleague, Dr. Brouillette, to wrap things up.
Okay, how can we intervene to improve brain health? Let's come back to the psychosocial framework that we are suggesting when thinking about brain health. And let me give you a concrete example from HIV of how using a broad psychosocial framework to brain health may change your approach in a clinical situation. So this is a study about switching from an efavirenz-containing regimen to an efavirenz-sparing regimen, and it's asking the question, does it improve cognition? So patients underwent a battery of neuropsychological tests at screening and again several weeks following the switch to an efavirenz-sparing regimen. I've shown here the result of 2 neuropsychological tests of memory and verbal, but more tests were done. I didn't show everything. The conclusion was neurocognitive functioning significantly improved in both arms, but there was no difference between the arms. Now, they also administered questionnaire to elicit cognitive complaint. This is the cognitive failure questionnaire, and here there was a difference. The decrease in cognitive symptoms was greater in the switch group than in the continuation group. The conclusion is the decision to discontinue efavirenz among otherwise healthy individuals should not be driven by the expectation of a cognitive improvement following the switch because it's unlikely to occur. Now, if you remember the slide that I showed earlier about the fact that symptoms, in fact, are associated with employment and presenteeism, whereas measured cognition is not, you would think that this is, in fact, a very interesting finding. Now, when you look at this framework to consider cognition in its impact in real life, you may think that it looks complicated. You know, you have to look at the individual, the environment, the biology, and looking at the context. But in fact, it opens up a lot of possibilities for intervention. I invite you to visit my poster on factors that influence productivity at work. But if I show here how productivity changed over time in our Positive Brain Health Now study, a finding that I report in the poster is that productivity was influenced by mental health, by vitality, cognitive symptoms, and pain. So there are several reasons to address these factors using a broad framework. Depression and anxiety, for example, can result from the environment, the experience of stigma, financial hardship, food insecurity, or from the individual, such as poor coping. Any of these may be amenable for intervention. Some are not, but many are, and some of these measures can be taken now. This is the information that we give to all the participants in our Brain Health Now cohort, and it can be found in our website. But the 7 tips to improve brain health includes, for example, to stop smoking, but also remaining socially active, doing physical activity, managing stress and negative mood, paying attention to your sleep, but also paying attention to the medication you're taking. And this is certainly a step that physicians can take to look at the list of medications, see if any of those could be negatively impacting cognition. Other steps that we are taking to improve cognition, and I invite you again to look at this poster from Nav from our group. She has developed a handbook for self-management of cognitive difficulties. So on one side, you try to improve cognition, but if you cannot improve it, you can look at the specific difficulty that people are experiencing and what kind of self-management strategies could be suggested. When there are several possibilities, where do you intervene? You look at the situation broadly, and you and your patients assess together what intervention is feasible, but also can have the greatest impact. Now, looking ahead, in the continuation of the Brain Health Now study, we are also developing an app that can be used by patients to assess their brain health, but also get personalized feedback based on the evidence that we have accumulated over the past several years on changes that they can make that would be associated with the greatest potential impact. So for patients, this is a very hopeful message that can be conveyed, that when it comes to cognition and brain health, they are not powerless victims to their biology, but there's a lot that they can do to protect their brain. In closing, I want to thank all the participants from the Positive Brain Health Now cohorts, our sites with the research coordinators, and the co-investigator of the study.
Hi, I'm David Vance. I'm the Associate Dean for Research and a professor at the School of Nursing at the University of Alabama at Birmingham. And I've had the pleasure to review these presentations today and to make a few comments to start our discussion today. So the topic is on brain health in adults with HIV, and this is a very important topic because over half of people with HIV are 50 and over, and we are concerned about their successful cognitive aging, because what we know right now is between 30 to 50% of people with HIV have some form of HIV-associated neurocognitive disorder. And so we, as people age with HIV, we're very concerned that as they age, as they are more prone to develop other comorbidities such as heart disease, hypertension, diabetes, that they're going to be more likely to have more brain insults as they age, which will further complicate their successful cognitive aging. So I was very happy to look at these presentations, and what has occurred to me as I read them is that a lot of them, I think, eventually lead to the idea of lifestyle and lifestyle implications. I thought the presentation on MRI and HIV was very consistent with the literature. We do know that HIV isn't necessarily associated with some of these problems, but we do see a lot of cortical thinning that's associated with HIV in the brain. What we also saw that was very encouraging is that there seems to be a lot of the cognitive functioning and seems to be relatively stable, and the neurological signs that we observed in MRI studies seem to be relatively stable over time. So that's an encouraging news. What I also thought was very interesting was his focus on employment, but with some of these, with one of these studies, and that I think that's an undervalued topic. We do know that people with HIV do work, and a lot of people with HIV don't work. And when we think about the advantages of employment, when you are employed, you are socially interacting, you're engaged in a higher level of interaction and activity. And it also puts you on a routine, which is very important for taking medication, sleep, and so forth. So I thought that was a very important point to make as well. And I was very happy to see that in the roadmap for brain health that there was also an emphasis on lifestyle. In fact, there were 7 indicators of lifestyle that were mentioned. And I think we're going to probably in our panel discussion talk about some of those right now. So thank you, and I now open it up for our panelists.
Well, thanks very much, David, for commenting and for joining us today. We're sorry that we're not all in person. We were looking forward to getting to know you personally, but we really appreciate your bringing your perspective to this work and to this broader problem. So now we're going to open it up for a sort of informal conversation, and I guess I'm going to act as the MC to avoid Zoom confusion. David was talking about successful aging in HIV. Nancy, I don't know if you want to comment a little bit on the work that you presented and the work that we've been doing and what you see as the prospects there.
Sure. Thank you. Thank you, David, for your comments. I'm Nancy Mayo. I'm a professor in McGill University and do a lot of work in health outcomes. And I was very happy to join the HIV team and look at the brain health outcomes. And one of the areas that I was very fascinated with was this emphasis on good outcomes in HIV. And sometimes we do emphasize in health conditions negative outcomes. So thinking about what makes people function very well, and can we learn things from high functioning people that we could apply in other areas and potentially look at interventions. In the study I did, we used the well-known SF36 as our indicator of healthy aging. It's a measure of health status and all of those areas, physical function and pain and, doing life roles are logical to define somebody who's doing well. We looked at the role of cognition in predicting successful aging. And our main finding, exactly what people are saying about their cognition, was the highest predictor. So if people were saying, I'm having trouble with my memory, I'm forgetting things, I'm not concentrating, that was highly associated with a successful aging. And there are interventions that can improve cognition. We're working on some self-management. There's a literature on the role of lifestyle and generally healthy living, cognitive reserve. But in addition to cognition and successful aging, there were lifestyle factors that impacted on successful aging. And a couple of them came to mind, that come to my mind now, is the opportunities for leisure activities. And that was a strong factor. It was also whether you were physically active, predicted successful aging, as did loneliness, stigma, how people feel about themselves. The main factors related to successful aging could actually, in addition to cognition, be classified under social determinants of health. And that's where the interventions lie, is that it's not just the medical team that needs to worry about these things. We as a society, for every part, all of our vulnerable populations, need to consider how important it is. Daily safety in your daily life. Is your neighborhood safe? Do you have enough money to meet your needs? Do you have a social network? Can we support a social network? Social network, and Leslie's an expert on this, will tell you that it's very good for your brain. So, that's a little nutshell of those factors relating to successful aging. Unfortunately, in this sample, we only had 14% that would meet that criteria of successful aging, which is really functioning at the age and sex normative values um, on those subscales. You know, maybe that's not the best definition, but you know, the norms are there for a reason. So I think there's a lot of work, a lot of opportunity for intervention by looking at that successful aging group.
So thanks, Nancy. David, I don't know if you want to chip in here on or tell us a little bit about your thinking around interventions and lifestyle interventions at the individual level versus these more social determinant interventions that are potentially higher impact, but of course more of a policy or a societal level point of intervention and less of a medical one. What are your thoughts on that, and have you been working on that?
Yeah, obviously, I agree with Nancy. There's a lot of, at a higher policy level, the social determinants are very important. But I think for the more immediate and more individual level, there are things that we can do for that. We already know from some of the literature that, and of course, depending on the study, but I think most of the literature does show that people with HIV generally don't have as a higher level of physical activity. And of course, that can be detrimental for just not for brain health, but also for heart health and other factors. So I think interventions to improve physical activities are very important. Some of my own work, we're trying to also improve just cognitive stimulation and just intellectual activity. So there's been a lot of studies on cognitive training. I do a lot of that myself, and the results so far are very promising, and that it just doesn't generalize to just cognition, but it seems to have some ripple effects in terms of quality of life and instrumental activities of daily living. So what I've seen in the gerontological literature, and I proposed for the HIV population, but haven't got there yet with my own research, is this idea of a cognitive prescription where, and we sort of see that in one of the presentations as well, where we emphasize different areas of lifestyle that we know are important for brain health and generally body health. So reduction of substances, increasing physical activity, improving nutrition, improving sleep quality, where we can actually have a behavioral modification for each person. It's individualized cognitive intervention that if people can work with the patient with this, then they can actually change things specifically for themselves at an individual level that hopefully synergistically can improve cognitive functioning. So there's a lot of work out there. The Age Well study is one of these studies that's been seen in the gerontological literature, where they actually work with people individually to change their physical activity goals, their sleep goals, their intellectual goals, and try to do that at a tailored individual level to improve these lifestyle factors that then can improve cognition, and with the idea of reducing the incidence and prevalence of dementia.
So just to pick up on that, one of the ideas that we've been pursuing in our ongoing research is that it's hard enough for healthy people with, top brains to undertake behavioral changes of this kind. And if you have some degree of cognitive difficulty, especially in executive function, which is really what you need to change your behavior in an ongoing way, that might be a special challenge. So in our project going forward, we're working on asking if cognitive rehabilitation strategies could be a useful pre-treatment prior to a lifestyle intervention to help people learn tactics to be able to make changes to lifestyle in a healthier direction. Just as a side note, maybe Marie-Josée, you're a psychiatrist. We've been talking about physical health and its connection to the brain so far, but I don't know if you want to comment on the links that we've seen in our study and that have been coming in general in relation to mental health and cognition, and whether this sort of holistic brain health approach might be a way past traditionally splitting those into two different categories.
Yes, I think one of the ideas when we were thinking about this study and what it would look like is we wanted to put, cognitive difficulty for sure, but we wanted also to put the brain in the context of people's lives. So asking what is the impact of these cognitive difficulties on function, such as work or quality of life, but also taking into account the fact that cognitive difficulties don't happen in a vacuum. They often come with difficulties in mood and motivation. It can be with anxiety. And then the environment, we've talked about stigma, about social support. So when you start putting all of that together, on one side, it makes it complicated, but on the other side, it also opens up a lot of avenues for intervention. Now, I agree that lifestyle interventions are important, but as Leslie said, even in the best of scenarios, they're difficult to initiate and maintain. And if you add to that, some difficulties with mood, maybe depressed mood, depressed motivation, social isolation, it becomes even more difficult to implement. So they're very important, but also very difficult to implement. So I think we also have to pay attention to the social environment and see if addressing issues such as increasing social contact and providing an environment that is going to give motivation, but also reinforcement to maintain the behavioral changes that we think would be beneficial in the long run. The attention to work, I mean, increasingly we're going to have to pay attention to that now that people are diagnosed early, treated early. They will want to keep working, and I'm not talking from a financial point of view only. I'm really talking about from the issue of work as contributing to quality of life, by, as you said, putting food on the table, providing some security, but also an opportunity for social interaction. And maybe in the best, of scenarios, providing something, an activity that's meaningful. But at the minimum, providing an income to meet one's needs.
So when the focus goes towards work and working well, that calls on a lot of cognitive and emotional resources. So it pushes the focus kind of up the ladder in terms of detecting and recognizing and intervening on very mild cognitive difficulties that might certainly far from a dementia category that might have been a traditional clinical focus. David, I don't know if you want to comment on how you've seen that in your work in terms of the level of difficulty or the severity, the focus. Where should we be focusing at the people who are actually in great shape now to help prevent problems, the people with mild troubles who could maybe be, with just a little help, be moved up to a place where they're functioning, across the line to function well, or the people who are really struggling, who may be struggling to be even independent in daily living?
Well, that's quite a tall order there. I think you're quite correct. It is really a continuum of care, a different kind of continuum of care. But when you intervene in terms of someone's cognition, I think it's still important to emphasize that most people with HIV are not going to have cognitive problems. And I think a lot of it is due to they're already being involved in their normal lives with employment and so forth. Now, those who are more at risk, we can intervene. For example, you were mentioning executive functioning probably being really one of those foundational cognitive abilities that people really need to focus on to have other improvements in their lives. So, and when you think about work, one of the top ones is executive functioning and memory. And even with our cognitive training protocols, we are able to improve some aspect of that. I think it's important as a caveat too with these cognitive training protocols is that they're not a panacea. So just because we give someone a cognitive training doesn't mean we can improve their IQ a certain amount. I think that's far reaching. What we can do is help them improve certain cognitive abilities and move it from maybe here to here, but there's only a small window for that. So if there's people are having certain cognitive abilities that are being jeopardizing their work, maybe we can work on that a little bit. And we also have some mnemonic strategies. We also have other cognitive rehabilitation strategies that can help with that. And also, there's also a point where we have to adjust our expectations as well.
I think one of the things that we've been learning that coming into this as a neurologist, I of course, I'm used to seeing people with Alzheimer's disease and other progressive conditions. And the idea of cognitive rehabilitation is not that pertinent in those conditions because the best you can do is hold the fort, and usually people are progressively declining despite your best efforts. But I think the main message that I've taken away from the work that we've done in the literature in the last few years is that the stability, even if people have difficulty and are performing in some cases below others of similar age and demographic background, they're holding steady, at least over the couple of years or 3 or 4 years that we have data on in various studies. So there's actually, it's plausible that cognitive rehabilitation might improve the situation as opposed to kind of throwing up our hands and saying it's too late, there's nothing to be done. But there's quite a lot potentially to be done, either with rehabilitation strategies or with optimizing medical care for those where or medical and mental health care where there's factors that could be immediately fixed. As you mentioned, substance use, maybe sometimes medication side effects or other things like that can be intervened on, in fact, quite readily. So one question, maybe I'll come back to you, Nancy, on this is how to help the clinicians and researchers interested in brain health and people living with HIV who are very interested in brain health, how to help people navigate that complexity, how to sort of tackle this. There's many opportunities to intervene, but where to start?
Right, good question, because the most important area about research is to translate it so that it actually impacts on the lives of people as opposed to just us. And one of the things that, and I know Mary Jose is very active in this as well, is to provide clinicians with very simple tools and directly to people themselves. I never separate that out. I'm always doing direct to patient marketing. Provide people with very simple tools that you can at least assess the brain health. Without these long, complicated questionnaires or long, complicated testing. So there's two approaches to take. One, and we've taken some of it by developing, short cognitive computerized testing, which can be done quite, without a long prescription and expensive referral based. But the other area are these very simple checklists for brain health. And some of the new research methods allow you to take these long measures that we've used before and shorten them. For example, we have a cognitive questionnaire that we've been using, and we've got it down to 6 questions. 3 questions will identify people doing really well, and 3 questions will identify people doing really poorly. And you can use all 6 questions and come up with a spectrum, but these are simple tools. Also looking at that spectrum of brain health. We've identified 5 areas, mood, but, including, low mood, anxiety, but also motivation and fatigue, and obviously cognition. So these simple checklists, you can put it on an app. The person can, monitor their own, well-being. I think this is very helpful clinically, is just to put the problem in the face of both the physician or the clinician and the patient, and then think of strategies. For example, fatigue. Fatigue is one of the highest symptoms in older people, and it's very high in our group. But quite often people say, oh yeah, everybody's fatigued. I'm fatigued too. But that isn't an answer. It's to look at it and say, you really do have fatigue. Why is that? You can drill down on that without it being a very complicated process. You identified sleep, querying about sleep, querying about substance abuse and things like that. Looking at medical reasons why people might be fatigued. So I think that this focus on brain health and not as an entity unto itself is very, very useful clinically, because putting like a small checklist in the hands of the patients, in the hands of clinicians, with with the and their knowledge of how to go laterally from fatigue or low mood, I think would be very useful. So we're very interested in short forms, absolutely highly validated measures, but essentially short forms, clinically useful measures.
Is that strategy something that you've been using in your work, David? Is that that kind of quick, sort of empowering, I guess, people to feel like they can tackle cognition without it being a multi-day voyage that would be best avoided?
No, I have not been doing that at all, but I love that idea. With my research, we give the full hour and a half psychological.
I'll give you 6 questions.
Yeah. So, and it's very expensive, and of course we actually then have to. It takes us probably an hour to 2 hours to then process that to see where they are on the hand continuum. So yeah, I have my own ideas about hand, and that is I don't think it's always the best idea to tell people that they have hand. According to our IRB, I had to tell people that they have hand because that was a criteria to be in my study. And so, I did not want to do that at all, but I thought, oh, well, we'll take advantage of this opportunity. So since I had to send them a letter saying they have probable hand, when they came back for our post-test, I did ask them what their opinions were about receiving that diagnosis. And surprisingly, a lot of people said, hey, I was glad to know of this. At least I can do something about it. I felt like I wasn't quite there cognitively, but I feel like now I'm empowered, I can do something about it. But not that was most people, but some people had a very negative reaction, as you can imagine. And what made me start thinking about this is in the beginning of my study, one of my dear friends was over at the house, and he's like, hey, David, I got a letter from you saying I have this condition. And I'm like, oh, dude, don't worry about it. It's more for me as a researcher that I know you have that. And then I explained to him, like, you could have had a bad day. You could have not had a good night's sleep. Maybe you had too much to drink the night before. I don't know. Maybe you're under a lot of stress. And because you can be, and as we've seen, you can be going through all this big neuropsych battery, and one day you can be neuropsychologically normal, and a week later you could be with mild neurocognitive disorder. So there's a lot of fluctuation there. So I question the value of that sometimes. So a smaller measure that really gets to the heart of where people are in terms of how they feel about their cognition is probably more meaningful.
Marie-José, do you want to pick up on that challenge of hand categorization? You have like 30 seconds.
30 seconds. We did do a full neuropsychological testing on 260 some people. And it was the exercise of turning this into a hand versus not hand classification was somewhat painful because different research group also applied different operationalization of the hand criteria. So the paper is being written up, but in addition to the challenges, as you're mentioning, of, depending on the day and so on, different groups also apply the criteria differently. So you could have hand if, I'm doing the rating, and not have hand if someone else is doing in the rating. So that's an additional, I guess, difficulty.
So, I guess we've been trying to steer clear of that categorization for various practical reasons, but also for the, I guess, conceptual reason that we think of cognition and brain health. Brain health is holistic and cognition as a continuum, and it's artificial to put people into boxes. It's more pertinent to know if the cognitive difficulties they may be experiencing are affecting their function, and if they're working at a high level, then even a small difficulty could have a big impact on function. And if they're not doing that, a big impact on cognition might not make much difference to their quality of life and may not be their priority. There may be other things that are more important for them to consider. The one thing I think that's worth reminding people is that the term hand makes it sound like it's something. It's not something like, streptococcal pneumonia is something. Hand is a descriptor and a syndrome, I suppose. And the causes are not, the term doesn't mean there's a cause, a specific cause. And I think what we've been seeing is there are numerous contributors, personal, medical, comorbidities, social, and so on. And that is, so people shouldn't feel once you've got hands stamped on your chart, that's it at all. It doesn't mean anything in a biological sense, like some diagnoses do. Like an HIV diagnosis, that means something in a biological sense, but a hand diagnosis is not the same. And there are numerous factors. Many of them are preventable or intervenable. And I think the challenge for researchers and clinicians is to help people prioritize where to intervene and when to intervene, and then to develop straightforward, clinically plausible, manageable approaches to understanding a person's own risks and giving them the tools to address them either on their own or with their community or with their clinical team. So we could go on about this at length, but I think we better wrap up in the interest of time. So I'll take the opportunity to thank David Vance specifically for joining us and giving us his thoughts on some of this work. And as usual, Nancy and Marie-José for the last several years of very interesting research collaboration. So unfortunately, in this format, we don't have the opportunity to take questions directly, but we would be very happy to hear from you. Feel free to email any of us. You can also check out the Positive Brain Health Now website. If you Google that, you will find links to our ongoing projects, or you can find any of us through Mr. Google as well. And we're happy to take email comments or questions. And for those in the Canadian research and clinical communities, we will be interacting with you through our various sites and in the next couple of years as we roll out more, we hope, evidence-based interventions and trials to develop that evidence base. Thanks for joining us today.